Well, what a fascinating morning that was. I mean, for me, it's been amazing because it's been very different from my usual zone. But I can see so many connections here. And because I was thinking, we've heard all this amazing stuff that's working across the world, and I'm going to bring it down to housing and ageing in the UK. But I think we can learn so much from each other. I think so much for me is about making connections between frontline reality, evidence-based policy, using the data, and sometimes you just have to state the obvious over and over again. And so it's been a very important, probably 30-year collaboration with the BRE. So I'm hoping to highlight how that works in practice. The good news is that you're all going to live longer. You're all ageing. Older people isn't somebody different. Some of us are a bit closer to one end than the other. And so don't switch off if you don't think housing and ageing is anything to do with you. It is. It will affect you in every way. So I really want to look in this session at the quality of housing, how that impacts on our health, our lives, our independence, and actually puncture some of the mythologies around ageing, which is what I feel I spend quite a lot of my time doing. So Care Per England, very briefly, set up by Shelter and Hacked in the 1980s to tackle an ignored issue of the large numbers of older people who lived in substandard housing. And the way that we've had to make this connection over the years is not just from a isn't it wrong point of view, but you have to put figures and quantify the gain of doing something about that poor housing. And increasingly today, the only show in town is the NHS. And if what you do saves the NHS money, and you can put a figure on it, it helps you to get some policy change and some action. And that really underpins a lot of what we do. So you can find out more about us if you talk to me afterwards. It's not just Care and a few other people saying that stating the obvious, a decent home underpins your quality of life. I liked what one of our previous speakers says, in that we don't just have a roof over our head. I say this so often, we have a home, or hopefully we have a home. Obviously, they've got the scandal of increasing homelessness, but we also need a decent home to live in, to function as a member of a community and a society. And how often I have to say the obvious of social care and health, it will cost you if you have substandard housing in this country. I'd be quite rich if I was paid a penny for every time I've said that. But the disconnect, even now, in the context of an ageing population, rising NHS costs, a growing inequality of the experience of ageing and our healthy life expectancy, not just our life expectancy, and it still seems that we're building totally inappropriate, poor standard housing. And that's my absolute frustration. I've heard all these fantastic presentations. It feels like we know what to do. The really big challenge is how do we get what is good spread at scale? Absolutely critical. So just to go on to, I'm going to look at very quickly recognising the realities, because this is where I think the charity sector, the policy sector, BRE Trust, it's a really important tripartite connection. The English Housing Survey is the housing data survey. And one of our big challenges to working with the NHS is awash with data. It collects massive data, has lots of information. The housing sector is very weak. We pretty much have the English Housing Survey, and its sample size, it's shrunk, how much it tells us is shrunk, but it's what we have. And the BRE Trust has done then fantastic additional work, because as well as the collecting of the data through the English Housing Survey, we've seen a shrinkage of what the government actually commissions to write about using that data. And so what we have done very much with the BRE is to work so that we mine some of the data that doesn't get published. And that has been critical, absolutely critical, in us making the case for housing action in this country to make homes better places to live. Really key, underpins all of our activities. I started by saying, don't switch off. Ageing isn't just about somebody else, it's about you. The image when I talk to most people in the NHS, in the social care field, is they think of old people as a problem, and they think most of them live in specialist housing, and if they don't, they should. And they don't tend to think about ageing as a process. And I use these statistics so often. And to say, you know, we've got 9.5 million elder households. This is not minority, and that's over 55. And we have a spectrum of some very healthy and fit over 55s and some very unhealthy and unfit over 55s. That chronologically, it's very diverse now. But that's the starting point. And 96% of us over that, as we age, will carry on living in ordinary housing. I know that all the push is for expanding retirement housing, extra care specialists, they all have a role, but they are still the minority issue. And if we're thinking about the health of our population, independent living at home, what really matters is that those, you know, that those 2 out of 5 homes in this country today lived by somebody with a head of household over 55. Very often, a lot of policy people are really good at thinking what old people should do. And I see a lot of policy driven by men in their 50s who think that their mother has made a terrible mistake by not moving into retirement housing sooner. You know, I kid you not, it goes to a very high level. Everybody's got an anecdote about the failing of their mother who should have done this sooner. And we should what we're embedded in so much is really listening to what people say. Now, if I went round this room and you said, well, what would be your ideal home? We are very different at all ages. And not everybody wants the same thing. And that's like, we're back to stating the obvious. But we like to put some data on that. We like to put some figures on it. And actually, if you talk to people, 80% will say, well, there's very high satisfaction with home and neighbourhood, and it rises with age. And interestingly, BRE data, it rises with under-occupation. Because not only are old people bed blocking, they're house blocking. But let's go back to what sort of homes we have, what people want, what their aspirations are, and then look at what we can do to support those aspirations. Most people want to live connected with their neighbours, their friends, their families, communities. Some people are actually very happy living on their own and not really seeing anybody else. You know, so living in a community of retirement housing is total anathema to some, absolute bliss for others. So let's get away from the stereotypes. Now, this is my big figure that presses the button sometimes for the NHS. Because if the NHS is interested in the health and the housing impacts on the health of its population, the biggest impact that we can have on the health of that population through housing improvement is by doing something about the quality of the existing housing stock. Probably if we recalculated that now at the current rate of rebuilding, there's probably gone down. I think current homes have to last about 1,200 years at current rates of replacement. So that one does fit. I try to remind people, older people live in all sorts of housing. And this is thanks to Simon Nicol. Simon Nicol, thank you for this slide. I have used it in so many places because it punctures the myths around where people live. Where old people live, old people or rich living in detached and semi-detached homes. No, they're not. They're spread right across. There are some variations over time and geographically, but this is just terribly useful. Probably we need an update. I must have been using it for 10 years. So that's how, sort of illustrating to you how we work together, using your data, using your analysis. I then take that into the policy arena, and I take it into the policy arena to try to drive solutions that benefit older people, and particularly disadvantaged older people. I've got a few slides that are a bit of an advanced view of a report that we're launching next week with the Centre for Ageing Better. We're working with them to try to put non-decent homes and improving the existing housing stock on the map. They've set a 10-year target for reducing the number of people living in non-decent homes by 1 million. And the BRE have been commissioned to do all the data analysis. So this is a tripartite piece of work coming out next week. And it's been quite a learning curve for me at the Centre for Ageing Better, because it's very driven by their comms people, so they've got a real eye for numbers and comms. And so there's a big headline just before, a few days before Christmas, where they pre-announced the 10 million people living in a non-decent home across England, and it got coverage. Now, when we start to actually look at the dwellings, you've got 4.3 million dwellings, and just under half of those are occupied with a head of household over 55. And I think that's an indictment of our society. But if we then go further and to actually start to look at that housing, because if the only show in town for housing and ageing is retirement housing, the only narrative on the whole that I hear around improving the quality of housing is the private rented sector, which has grown exponentially, and where you've got the highest percentage of non-decency. And you've got the social housing, which, because of the Decent Homes programme, underpinned BRE data, is the least likely to be non-decent. But where is your real concentration of non-decent housing? It's in the owned and occupied sector, for all sorts of reasons that I haven't got time to go into, but that's the reality. And if I say do a workshop with health and care workers, and I ask them where they think older people live, they will invariably overestimate the number that live in social housing. And we've just got this invisible group because of an ideology, I suppose, in this country that once you're in a homeowner, everything's over to you. And it's just so much more of a complex picture than that. And also policies driven largely by London and the South East, where equity levels are very high, and not by people who live in Oldham and Blackburn and County Durham. So this is all about using data to try to shift that thinking. Now, this is the one, I'll explain why I think this is such an important finding from the work that I've just done with BRE, is we're seeing this numerical growth of just over 31% of the number of over 75s living in a non-decent home. And this is so relevant when it comes to health and housing, because health analytics will show that your use of the NHS really starts to go up post-75. So if you want to get if we want action to address this non-decent housing, to improve our housing stock, we've really got to get health on board and the NHS on board saying, yes, we need to do something. And that's because when we start to look at what are the health conditions that the housing quality impacts on the most, any medical person will see that those things are mostly long-term conditions which can't be cured, which increase in their incidence in later life, and are the ones that are going to cost the NHS the most. And so if we really have to prevent this by building healthier homes right from the start and improving our housing stock for all ages. And then we use BRE data to show that the really big picture issues where you could improve health through tackling the non-decent features in the home are falls, hazards and cold homes by a mile. What is the biggest cause of death, premature death and injury amongst an ageing population? It's falls in the home. Yeah? So if you can do quite small things in a home to reduce the falls risk, you can put a figure on saving the NHS money. Cold homes, this is where I always worry about the disconnect, because you've got a lobby around affordable warmth, energy efficient housing. We saw a Decent Homes programme that made huge gains, and we really missed a trick on making the connection between accessible and reducing health risk and falls risk at the same time that we went in and did something about the heating system. And I worry that we're going to make the same mistake again by hopefully chucking some money at our problem of carbon emissions and miss a trick again on making our homes safer and more accessible. And so I think I just want to keep bringing these together. So we then mine that further and we really bring it home to people using the BRE data analysis These are the, if you don't understand the housing health and safety rating system, you'd need a long time to explain it. Just take it from me, you've got a whole list of hazards. Yeah? And that's the incidence of the category 1 hazard. A cat 1 hazard is a serious risk to the health of the occupant of the home by the presence of a hazard in that home. Now, right at the bottom, sorry you can't read it, but the big line at the bottom is excess cold. The next line is falls on stairs. The next one, falls on the level, falls between levels. If I add those 3 falls one, you can see what should we be tackling in non-decent homes to impact on the health service. Cold homes, falls. Simple. Right, so what do I then do? This is a couple of illustrations of how, we've got 5 minutes, of how we worked with BRE. BRE do my data analysis, the data crunching. I then turn that into combining it with other data sources, and this has underpinned our work and our work programmes and our profile raising and our campaigning for policy change. So perfect storm, maybe that's a bit negative, but you know, we have ageing population, low income home ownership. I've talked about disadvantage, but the social revolution we have seen since the 70s, and okay, we're going a bit into reverse now, is low income home ownership. 1970, about 50% home ownership. We then saw not just right to buy, it wasn't just right to buy, you do the data, you do the sums, access to borrowing for non-middle class people, revolutionised housing tenure purchase during the 1980s after changing the housing market in 79. And so then we've peaked at 76% home ownership, 78% now amongst the older population, and that growth was in lower income groups who are now low income pensioners. And we haven't shifted any of our thinking about maintenance of the housing stock. We haven't changed our welfare system, so you'll get housing help for your rent, you get no housing help if you're a low income homeowner, living in low equity property in a poor area. Let's just put some reality on this. This is just an extract from one of the reports. Mr. Monk, only 67, not very old, yeah? Lived in the home he grew up in, cared for his parents, so he never had a very good job, low income, no savings, owns the house outright, fine. Major health problems, breathing difficulties, crumbling spine, breathing limited, vulnerable to cold, lots of health service costs, lots of GP visits, in and out of hospital. Did anybody look at his home? No. Yeah, so living in a cold place. Weaker, that's West of England Care and Repair. They were finally contacted when part of the ceiling collapsed. So a caseworker went into the home and actually could then solve so that it was cold, it was damp, the heating and the boiler had been disconnected, smart meter, they'd come in to put the smart meter in and just disconnected it because the gas fire was down. So we've seen all this cost the NHS. I sit around putting figures onto this sort of case and then compare that with the figure of making that home decent. And that, I think, is very convincing. Not to lose the adaptability and the accessibility of the housing stock. We have such an inaccessible housing stock. It's stuck at around 5% for years. The Code for Sustainable Homes, which drove up the design standard of social housing for a few years, then it went, created that 2% gain. So we've got, but it could be adapted to a basic level. So just trying to pull all this together very quickly in the last couple of minutes. The greatest health impact using the BRE data, using all the things I've explained, is if we tackle the existing housing stock. And I think that accords with a lot of the carbon agenda as well. It's an opportunity to build evidence of what works. If we have programs where you actually monitored the health impacts of your intervention, that would help to build the case for around social gain for the future. I also think that could influence new home design as well. And we need the evidence all the time from BRE about the health cost of poor housing to try to drive up standards. I despair sometimes that we are, successive governments are so reluctant to enforce higher standards. Without enforcement, we won't see improvements to new home design and new home building, I'm absolutely sure. We're up against firefighting all the time. There's lots of rhetoric around prevention. The NHS plan says it's all about prevention. Social care said, the Care Act said it was all about prevention, but actually what everybody's doing is firefighting. And everybody's scrambling over their budgets. So I have heard too often housing authorities saying, why should we put some money into home adaptations and improvements? The main gain is to the NHS. Yes, and? So, just to flag up a few things, 2010, we saw a complete cut to all housing, private sector housing renewal funding. It had been there since 1945. BRE came in with this incredibly influential report about the real cost of poor housing, and I have used and quoted the subsequent updated figure more often than I can imagine. Poor housing costs the NHS 1.4 billion. It is so useful, it is so influential. The BRE Trust has put out information about homes and ageing when government stopped using the English Housing Survey to publish reports about homes and ageing. Absolutely key to everything that we do. The cost from preventative housing intervention. So if you adapt before a crisis, we've got a figure to put onto that. And your new report, that's going to be so helpful and so useful. And there have been real world impacts. We saw about $1 trillion spent on the Decent Homes programme. Absolutely transformed the quality of social housing. It was brilliant. We've used all these sorts of figures. We've now got a doubling of the DFG budget. Who knows what's going to happen in? Well, I'm just holding my breath for the budget, but let's hope we hang on to that. It's enabled us to make the case for preventative handy help services, home improvement agencies for selective interventions, and we've got a place at the table which sets the national policy on false prevention, which previously was all about medical interventions, check people's drugs, get them to do exercises. Fine, what about the buildings they live in? So we've managed to get that in there thanks to your sorts of evidence. So on the horizon, an NHS long-term plan, we've had a prevention green paper. We may or may not get a prevention white paper. I was told yesterday there might be something in the spring, but prevention is all. And we've got to shift it away from a sole focus on behaviour modification and actually think of the wider social determinants. And please, Mr. Marmot, come back. And building standard regulations, we're going to see changes. Can we make them good enough to create healthy places to live for all of us at all our ages? Thank you.